Hello, and welcome to Basics to Brilliance Haematology Podcast, the podcast series that will take your basic haematology knowledge up to a level needed to be an effective haematology registrar. We hope that the content we cover here will help you prepare for the dreaded Haematology FRC Path Part 1 examination. But most importantly, we hope that this series fills you with excitement for the fantastic, dynamic and highly rewarding specialty of haematology. My name is Dr. Anharad Everden, Haematology ST5 Registrar in the Southwest Deanery.
And my name's Dr. David Fazy, Haematology SHO, with aspirations to be a haemorrhage.
And let's get started on today's topic.
From basics
to brilliance. Hi, David.
Hello.
How's it going?
Good. A sad day, I hear.
A sad day?
We are at the bottom of the clotting cascade.
Yes.
Your joy and enthusiasm for all things clotting.
I know. And what a way to spend a bank holiday doing the clotting cascade.
We're fun people.
I've just outed us, haven't I? Sorry. So today I thought we would spend, well, as you say, we are getting to the end of the clotting cascade now. So we're looking at that very bottom part of you tell me, what's at the bottom of the clotting cascade, David?
So I hope it's factor 13,
which is
our fibrin stabilizing factor.
Very good. Yeah. So we're looking at, that's the area that we're looking at. So I thought we would start with a case. This is a made up case, but based on how this would present. So I get called about a baby.
Okay, bad start. Instantly, that's like a big red flags.
Yeah. You're right. So baby who has had repeated bleeding from the umbilical cord. So firstly, the stump kind of dried, but then took a while longer than expected to fall off. And the parents have brought the baby back in because it just keeps bleeding from the site every few days. And so that's what initially happened. And then, sadly, the baby then was discovered to have an intracranial hemorrhage. And it's at this point that you get a phone call to haematology. So what would you want to know in this case if you're the haematology reg?
So I would start, as we always start, with a history.
Mm-hmm,
I guess that's the the history won't be too long. I guess a family history as well will probably be quite useful.
Yeah.
I would then do a sort of a standard set of bloods. So I would get a full blood count, probably a film as well. So I could see if they've sort of, platelet problems.
Okay.
Coagulation screen.
Large platelets in like some of the platelet disorders. Yeah.
Ones that I'm sure we'll discuss in platelet disorders at another time. And I'll get rinsed then. So then, a coagulation screen would be my next step.
Yeah, so a PT, APTT, and fibrinogen. Yeah, good. And just to say, in the bleeding history, as you said, we've already got about the two things: the delayed falling off of the stump, and then the intermittent bleeding. But you could also just check that the baby's had vitamin K after delivery, for example. Okay, good. So you do an APTT and a PT, and they come back as normal. And the full blood count is also normal, and the blood film is unremarkable. I mean, it's a baby blood film, so it's pretty scary. Everything's very sort of left shifted, nucleated red cells. If that was an adult, you'd be freaking out, but for a baby film, it's fine.
So call an adult. Yeah.
And you would also do a fibrinogen in this situation, and that comes back as normal. Where are you going to go with this next?
So I guess I'm heading towards factors. And maybe von Willebrand as well. So with von Willebrands, I do a factor screen.
Mm-hmm.
And if, I'm not trying to be poked by the fact that we're clearly doing a factor 13 broadcast, but I think that is probably as far as I would get before I would be probably well out of my depth.
Okay, yeah, fine. And I'm glad you didn't say anything about platelet aggregometry, because you definitely don't do that until they're sort of above the age of 12. But you do consider in the back of your head when everything else comes back normal. So we assay factor 8, 9, 10, 11, 12, 7, 2 and 5, and they all come back as normal. And so you're like, this is weird. So then do we just run a factor 13? like all the other factors?
So I'm guessing by the way you're asking me the answer's no, but I don't know how you test for a factor 13
Okay, good. Well,
deficiency.
let's come back to this case. But yeah, a bit of a clinical conundrum if you don't know about factor 13, because you've essentially got normal factor levels, a negative von Willebrand screen, and a normal full blood count, normal blood film, and yeah, a significant bleeding history now with an intracranial hemorrhage. So we'll come back to that in a minute. So we've already alluded to the fact that it's factor 13. Do you know what the role of factor 13 is?
So from what I understand, it cross-links fibrin clots to make so effectively stabilize them, protect them from things like mechanical stress.
Yes.
Yeah.
Yeah, very good. So it's quite different to all the other factors that we've talked about, where it's a kind of a cleaving proteolytic cascade. When once you've had your fibrinogen turn into fibrin, and then you've got your sort of fibrin mesh around your platelets to form your secondary hemostatic plug, your factor 13 then comes in to then, which gets cleaved by thrombin, to then basically the catalytic subunit A's of the factor 13 then kind of undergo a conformational change and expose a site that reacts with the fibrin monomers and basically allows cross-linking of the fibrin mesh to basically, as you say, stabilize the fibrin clot. And so it cross-links the fibrin chains, and that increases the clot strength. And it also cross-links fibrin to something else called alpha-2 antiplasmin, which reduces fibrinolysis. And so therefore, not only are the clots stronger, but they're also sort of more resistant. And therefore, if you don't have factor 13, you will form an initial clot, because obviously we've done the clotting cascade down to the formation of fibrin, but then they'll start to break down and they'll bleed again. And that's the kind of classical thing that you see with a factor 13 deficiency. Yeah, good. So then the next thing to say is, do you know anything about people that have factor 13 deficiency?
So, I mean, this is me completely guessing, I
Mm.
suppose. It's just based upon what we've been talking about. I
Hmm.
suppose I guess their coagulation screen looks completely normal, and yet they just continue to bleed. And I
Mm.
imagine I can't imagine it's particularly catastrophic, but I imagine it just continues.
Okay. I
That
mean,
would be my guess.
yeah, no, it's good. I mean, it's firstly, it's very rare. Secondly, it's autosomally recessively inherited. And actually, it can be quite catastrophic if you have a severe deficiency. So often it will present with babies. And they often present with this repeated bleeding from the umbilical cord, and as I said with this case, delayed dropping off of the stump. But up to a third of patients with severe factor 13 deficiency can have an intracranial hemorrhage, which obviously can be life-threatening. You can also be an adult if you've got a milder form and have factor 13 deficiency diagnosed at that point. And that's usually with epistaxis or gum bleeding, bleeding into muscles. Women will have menorrhagia. And also, specifically, there's a risk of early miscarriage and bleeding in pregnancy. So, factor 13, for whatever reason, is particularly important in pregnancy. And men have reduced fertility and reduced sperm count as an added side note. So, that's something else that could be a bit of a diagnostic clue. But yeah, so it's really important, factor 13, not only in maintaining the strength of clots, but in maintaining pregnancy, in bone and cartilage growth, and in wound healing as well. So it's actually quite an important factor. And it's important enough that if you do have a severe factor 13 deficiency, then you do need to have long-term prophylaxis using Novo 13, which is a recombinant factor 13. And that's mainly because of their high risk of intracranial hemorrhage. And the good thing about Nova 13 is that it's got a really long half-life of 7 days. So they generally inject once a month. So it's kind of better than that of your factor replacement in haemophilia A when we talk about that, with less frequent injections required. So that's factor 13.
So basically, I sold it short. It is a big deal.
Yeah,
Pay
it is.
attention. Got it. Yeah,
Yeah,
got it.
exactly. But it's super rare, David. But it's more,
Okay.
it's probably overrepresented in exams because it's one of the examples where a clotting screen and even factor assays are not going to pick it up. So why is it that we can't just do a normal factor assay like we do for all the other factors for factor 13? Do you know? Or could you work it out from first principles?
I mean, that's mean to say it like that.
Sorry.
Can you not be stupid and work it out? So,
Sorry.
I'm not. I take it sort of circulates in the blood the standard way any other factor would.
Yeah,
so you
that's
should
right.
be able to do a quantitative study.
Okay.
I don't sort of get why we wouldn't be able to do it that way.
Okay, so do you remember how the lab machines detect the end point of clotting?
With they shine a light through it, and
Exactly. Yeah. So mainly they're photo-optical methods, and you shine a light through, and as the clot forms, it reaches a certain optical density, and then that said, okay, clot has formed now. Once you've formed these fibrin strands, actually,
yeah.
that's when the time stops. And actually, factor 13 almost works after that point because it's cross-linking the fibrin strands they're formed, and so as a result, it's not measured on any clotting test that we have.
Oh, I see what you're saying.
So
yeah,
because it's almost happening after the time that we've stopped the timer.
Yeah. So I was trying to work out is there such thing as a factor assay? I guess a quantitative.
No, there is
like you would no. Okay.
no because
everything's done as an analogy almost, isn't it?
So because everything that we've done so far is a functional assay.
It's a correcting study and a mixing study.
And it's all
I see.
Because they're all functional assays, aren't they? That's the beauty of clotting, is that we're not doing ELISAs to measure the amount of factor 8. We're doing a clotting test, and we're measuring the endpoint as formation of a clot. And I think that's why people like talking about factor 13, is because it happens after that, and so it's something that none of our tests that we've talked about so far would pick up. So can you imagine any way that we might try and instead detect factor 13?
But you mentioned an ELISA.
Yeah.
I would probably go down that route. Or do you do something smart with like a PCR or something, and you do it from a genetic level?
No.
I don't know. Am I going too far?
No, you're fine. ELISA is correct. You can definitely do an immunological assay. And the ELISAs are for the subunit A, because factor 13 is made up of 2 catalytic A subunits and 2 non-catalytic B subunits. And so then when thrombin comes along, when you're making your clot, it cleaves off the Bs and allows the As to be active and go and do the cross-linking of the fibrin. And so the ELISA is against the factor 13A subunit, and so can just measure how high or low the level is. I mean, obviously, the issue with any ELISA, as we've discussed before, is it's a non-functional assay. But most of the time, if you've got a factor 13 deficiency, it is due to a quantitative problem rather than a qualitative problem. So in itself, it's not too much of an issue that it's a non-functional test doing an ELISA. So an ELISA is certainly one way that you can measure factor 13. The other way that you can do it, or how we used to do it back in the olden days, is we literally used to take blood, let it clot, and then chuck the clot in a whole load of urea and then see how much it's dissolved by the morning, sort of thing. Obviously, that's got lots of problems. It's called the clot solubility assay, and just to be a bit more detailed about it, you basically take your plasma samples, your patient sample and your control sample, and then you clot them with the excess of calcium, and you incubate at 37 degrees for 30 minutes, and then you place that clot in 5 moles of urea, and you incubate it for 24 hours. And if the clot has dissolved after 24 hours, then it suggests that there's a factor 13 deficiency. Obviously, that has loads of room for interference, particularly if you didn't have enough fibrinogen, or if your fibrinogen didn't work, then in particular, that's going to affect that. So we don't do the clot solubility assay. And instead, we do have a functional assay for factor 13, which is called the ammonia release assay. And basically, this is kind of taking advantage of the fact that when factor 13 works, it cross-links the lysine residue from one fibrin to the glutamine residue of another fibrin molecule. And when it cross-links it releases ammonia, and that's called a transglutaminase reaction. And so basically, you can take the patient's plasma, and then you can add in a synthetic amine peptide substrate to allow the factor 13 in the patient's plasma to work on that and generate ammonia. And then you can basically measure how much ammonia is made through it changing the colour of, one of your color substrates, so your glutamate dehydrogenase that converts NADPH to NADP plus, which then, will change a color change and you can detect it that way. So you can do an ammonia release assay as a functional assay of factor 13. So that's what we generally do, that plus an ELISA. And then if they are low, then you would do a mutational analysis to basically confirm the diagnosis. So going back to that case of the baby, once we'd done our sort of von Willebrand screen and all of our factor assays, and if they came back normal, then we'd want to be moving on to things that can't be detected by your standard clotting tests, and that is your factor 13 assays, so your ELISA and your ammonia release assay. And also you'd probably do like a PFA, so a platelet functional assay screen, and start thinking about platelet functional disorders as well. Cool. Okay. I think that's everything to talk about with factor 13. It doesn't do that.
Oh, job done. Thanks very much, guys. It's been a pleasure talking to you.
No. Let's talk about other things to do with the end of the clotting cascade. So I think the next thing really to talk about is fibrinolysis. So we formed our clot, we've cross-linked it. Now, how do we get rid of the clot? Because otherwise we're going to clot off our whole body. So what is fibrinolysis, David?
So it's a physiological process. It's a normal process by which is triggered during clot formation to ensure clot resolution.
Yeah.
From what I understand, it involves plasminogen being converted to plasmin, which then does some breaking down of stuff.
Yeah,
that's good. As far as my those are my words. Yeah.
No, that's really good.
Yeah.
I mean, the crux of it is plasmin. So the crux of clotting is thrombin, and that converts your fibrinogen into your fibrin. And then your crux of fibrinolysis is plasmin, which basically converts your fibrin in your clot into fibrin degradation products, or FDPs. Yeah.
And that's where we get our D-dimer from, isn't it?
Yeah, very good. Yeah, exactly. What sort of things trigger fibrinolysis?
So I from what I understand, it's the process starts when clotting happens. It's sort of almost like a feedback, isn't it? So that actually you don't end up with hideous like DIC all over your body. So actually you can actually control your clots after they start.
Yeah, exactly. So any tissue endothelial damage, you're going to get activation of the coagulation pathway and the fibrinolytic pathway simultaneously. Very good. And that's really important, as you say. So the clotting cascade will be activated by the extrinsic pathway. And when there's endothelial damage, you start getting the slow release of tissue plasminogen activator. And basically, I think a key thing to understand is that fibrin actually kind of harbors a means of self-destruction via the fact that it has these lysine residues, which provide sort of docking sites for the two key fibrinolytic components. So once you've made fibrin is great, but it almost has its own auto-destruct by having these lysine residues. And the lysine residues provide docking for two key things. Firstly, plasminogen, which is the key substrate, because plasminogen will then become plasmin, which then will break it down. And also, the other thing that binds to the lysine residues on fibrin is tissue plasminogen activator, which is the key activator. And so basically, being able to bind to fibrin in a clot, these two components, plasminogen and TPA, allows the whole process to get started and sort of therefore localize.
It's effectively, fibrin's its own catalyst of its own destruction.
Exactly, which is really quite neat and cool. So plasmin is an enzyme that's made in the liver, and as you said, or as I said, I can't remember who. It's made in an inactive form, plasminogen, and plasminogen circulates around in the bloodstream, but it's only when it really binds to fibrin that it becomes very sort of attractive to tissue plasminogen activator. Okay, so before that, it's kind of floating around, not really doing very much. And then when some clot forms and some fibrin's there, it's like, oh, lysine residues. And it sticks to the lysine residues. And then the TPA is like, oh, that looks like quite a nice plasminogen. I'm going to go and activate that into plasmin. So that's kind of how I think about it. Sorry to try and make it a bit more kind of.
No, I think, like you said, as basic as possible is probably just right out my street.
Yeah, cool. So you've got this clot with fibrin with all its lysine residues on, and then you've got your damaged endothelium with your TPA that's been released. And basically, tissue plasminogen activator is the principal activator of fibrinolysis. But it has a very short half-life when it's just freely floating in the blood. So it only lasts about 2 to 3 minutes, and that's due to the presence of these inhibitors, plasminogen activator inhibitor 1 and 2. And they basically mop up any TPA within the blood that's free floating, because we don't want free floating TPA being able to kind of cause any havoc. We want it to only work on clot when it's formed. So when TPA then binds to lysine residues on fibrin on a clot, it then suddenly develops a really long half-life. And so it can then, have much more prolonged effect on the surface of the clot. And then basically its affinity for plasminogen is massively increased, as I said, once plasminogen is bound to the clot as well. And so then that's then what accelerates the conversion of plasminogen into plasmin. Do you know of any other activators other than TPA of the fibrinolysis pathway?
So this is a bit of a stab in the dark. Mm-hmm. We use urokinase, don't we?
Okay.
As part of a anticoagulate lines and things. Mm-hmm. Does that have something to do with the pathway?
Yeah, so very good. So uroplasminogen activator, or UPA, is the other one, and that's a secondary activator of fibrinolysis. It's got the U in front because it was first discovered in urine, and it's made by, instead of being made by damaged endothelial cells, it's made by macrophages, monocytes, and urinary epithelium. So that kind of makes sense because you get your initial damage of endothelium and your TPA gets released, and that's your initial activator of fibrinolysis. And then your monocytes and your macrophages and your inflammation is going to move in, and that's therefore going to release your secondary activator of fibrinolysis, which is your UPA. Okay. And the difference in UPA versus TPA is that UPA doesn't need to have fibrin as a cofactor, so it doesn't need to bind to the clot to work. So in that way it's more dangerous, but it does have a lower affinity for plasminogen, so in that way it's less dangerous, if that makes sense. So it's not got this beautiful thing that TPA's got where it floats around in the blood with a really short half-life, and then when it binds to lysine on the fibrin in the clot, it then suddenly develops a really long half-life and then starts activating plasminogen into plasmin. Instead, it kind of, the UPA doesn't need to bind to the clot, but it's not as kind of strong as TPA. And all it really does is plasmin basically causes the activation of UPA, and so it forms a positive feedback loop. So once you start getting some plasmin formation, UPA will be released from white blood cells which are in the area, and that will cause a positive feedback loop to create more plasmin. Does that make sense?
As long as there's a way to turn off everything. I guess the immune system has its own sort of feedback loops, doesn't it, with regulatory cells? So I guess that's actually, that also activates as soon as the white cells are activated. So no, that makes sense.
Yeah, so you got your initial
bit of redundancy.
Yeah, exactly. So you got your initial TPA released from your damaged endothelium, and that's the main thing that causes plasminogen into plasmin. But then once your plasmin is made, that then activates UPA, which does a positive feedback, making further plasmin. So as you say, you do need some inhibitors to keep this stuff in check. And I mean, obviously there are already things that are keeping it in check by the fact that TPA needs to be bound to the clot, for example. But some of there are some other inhibitors as well, which are really helpful. So the main inhibitor of fibrinolysis is, as we said, the PAI1 and 2, which is the plasminogen activator inhibitor. And basically, those molecules float around in the blood and they inhibit both activators of fibrinolysis, so TPA and UPA. And they basically bind to TPA and UPA to form complexes, so PAI1 TPA complexes, which are then just cleared by the liver. And they're stored in platelets, so, they're going to get released locally by platelets. And so they just kind of limit how much TPA there is and UPA there is to just keep things under control, as you were saying. And they're also what are responsible for the TPA having a really short half-life if it's free floating in blood, because it's just going to get mopped up by this PAI1. As if it's bound to clot, then they can't bind and make complexes and get cleared by the liver. Yeah? You still following?
Yeah, no, it's nice when the naming nomenclature makes sense.
yeah, it gives you a clue what it actually does. Yeah, exactly.
Yeah.
And then we've got the second of the inhibitors is the TAFI, which is the thrombin activatable fibrinolysis inhibitor. And this one is activated by thrombin binding to thromboembolin on endothelial cells. And it basically works by cleaving off those lysine residues on fibrin and therefore removing the docking sites for the plasminogen and the TPA, and therefore basically kind of protecting fibrin. Does that make sense?
Yeah.
Cool. So that one's also made in the liver and stored in the platelets. And then the third inhibitor is the alpha-2 antiplasmin. And that's the main molecule that inhibits plasmin directly. So if you start getting too much plasmin, then your alpha-2 antiplasmin is just going to come and mop some of that up. And that also keeps a lid on how much plasmin gets generated in that positive feedback loop. And then you've got factor 13, of course, which also cross-links the fibrin and therefore makes the clot just generally more resistant to fibrinolysis, because the factor 13 is basically giving the plasmin more work to do because it's got to do more chopping to get them into fibrin degradation products. So
Right.
that's your activators, your TPA and your UPA, and then your inhibitors, your PAI 1 and 2, your TAFI, your alpha-2 antiplasmin, and your factor 13. And they kind of work together in this amazing positive and negative feedback loops to kind of keep the whole thing controlled. And it's amazing, really, that we can have some damage and some inflammation and form a clot in the right place that doesn't spread around the whole body and also goes away and gets digested once it's done its job and achieved hemostasis. It's quite remarkable, isn't it?
Yeah, for sure. In like you said, in a dynamic, moving place that you want to create a blockage without giving yourself a stroke or an MI is pretty good.
Yeah, really amazing temporal and spatial control. Okay, so then what's thrombolysis, David?
So breaking down of clots, if I was to take the words, yeah,
it's basically deploying fibrinolysis that we've just discussed for our own benefit medically. And when would we want to do thrombolysis?
In cases like large PEs where it's causing significant trouble and strokes.
Yeah, so in unstable PEs, so either massive where you've got a systolic blood pressure of less than 90, I think, for like 15 minutes, or a submassive PE, so where they've got right-sided heart strain or they've had an MI from the PE, and stroke within 4.5 hours. And then I guess acute coronary syndrome, but that's rare those days. But I guess if you didn't have primary PCI and you had somebody that was really unstable. So those are the situations in which we would deploy thrombolysis. And just to be clear, what's the difference between thrombolizing somebody compared to just anticoagulating them? Like, what's the general difference?
So anticoagulating doesn't break down the clot. Moreover, it stops more clot being formed, while a thrombolytic process is breaking down the clot.
Yes, exactly.
From what I understand.
Yeah, exactly. I think of thrombolysis as basically sync blocker. And essentially, that is what we're doing when we put urokinase down lines, for example, when they're clotted. So, yeah, it's properly digesting the clot. So it's quite a drastic measure. So when we're doing it in things like stroke, it's because we're trying to rapidly increase the perfusion of the brain to try and save that penumbra area, aren't we? Cool. So what drugs do you know that can mediate thrombolysis for us?
So the only one that I've heard of is alteplase. I know there are other places which are probably used elsewhere, but alteplase is what we use in my trust. Yeah,
exactly. And do you know how the mechanism of what it is or how it works based on our amazing knowledge of thrombolysis now?
So is it must be akin to plasma in some way. It must be something that breaks down fibrin clots.
Okay.
If I was to guess.
So what would be the issue? I'm glad you said that, because what would be the issue of giving IV plasmin?
Oh, it's going to go everywhere.
Exactly. It's going to just digest like every clot that's there. And what do we really want? We want something that's going to work more
localized.
locally.
Yeah.
Exactly. So instead, alteplase is actually recombinant tissue plasminogen activator, which is kind of really clever because we give TPA knowing that it's only got a really short half-life. So its half-life is like 5 minutes because it's loose in the blood. But they always say, the effect is much longer. And of course, the effect is much longer. And we know that because it's going to get mopped up quite quickly by our inhibitors like PAI1. But if it goes and finds lysine residues on a big chunk of fibrin in a big clot that's blocking, someone's middle cerebral artery in their brain from a stroke, it's going to go, ooh, bind to that. And then the plasminogen is going to be bound to that clot as well, and is going to therefore look really attractive to that recombinant TPA, which is then going to convert that plasminogen into plasmin, but quite nice and locally within that clot. So it's quite cool because you're going to give it IV, but it's actually going to gravitate and activate fibrinolysis to the area of the clot. And that's why we don't give something like IV plasmin. So, yeah. Side effects of autoplays, things you know about that you need to worry about? It's more of a stroke reg thing, isn't it? But it's worth knowing.
Why don't you tell us?
Okay, bleeding, obviously.
Yeah.
It can also cause like a transient hypotension. People can get allergic reactions. You can get a bit of a fever after having autoplays, and sometimes it can cause a cholesterol embolism. But yeah, the main thing is bleeding. That's the main thing that we're going to get called about. And then you've got any other ones that you know about thrombolysis that we use much less, to be honest. We used to use it.
Sorry, so
Any other mediators of thrombolysis that we use? You've said alteplase, which is our recombinant TPA.
is this like streptokinase?
Yeah, exactly, streptokinase, and that's called streptokinase because it's extracted from streptococci. So it's a bacterial product, but it also binds and cleaves plasminogen into plasmin. So it sort of replaces the role of TPA rather than it being IV plasmin or anything. So again, it's going to be quite localized to where there's clot. And I guess the bacteria used to make this product to kind of get rid of clot and allow them to move around the body better or whatever. But anyway, so we don't use it so much anymore, mainly because it causes allergic reactions and you can get anaphylaxis because it's made from bacteria, I guess. And those antibodies can hang around for a really long time and cause either allergy or a lack of response in the future. So we don't really use streptokinase so much anymore. I think, I'm not sure if I ever saw it in F1, but certainly nowadays it's always autoplays, isn't it? But it's good to just think about how the mechanism of that works. And then you said urokinase as well, which is really useful for putting down PICC lines on haematology wards in particular. So you just give your sort of 5,000 units down the line and hopefully that digests it and then they can start taking bloods off it again. Great. Okay, so shall we do a bit of a case?
Yeah.
Okay.
I'm ready-ish.
Okay. So this is a case actually that I have had quite a few phone calls like this. So I was called about a patient that has had a stroke and then they were thrombolized about 24 hours ago, and now they've dropped their GCS, and the stroke reg has got another CT, and they've had a haemorrhagic transformation of their stroke area. So what can we do? Please help. How are you going to approach this case?
So we've had a stroke and now we've got a hemorrhagic transformation is basically
Had a stroke,
what we're...
was thrombolized, and now has had a hemorrhagic transformation. Yeah.
So I guess in my head, I'm thinking, can I pump up their clotting factors or the things that we have now inhibited? Mm-hmm. Can I give them sort of, I don't know, FFP or something like that? Can I give them back the factors that we have effectively stopped working?
Yeah, okay. So our general advice is going to be take a full blood count because you're going to want to check hemoglobin and platelets, PT, APTT, and fibrinogen. And yeah, I like how you're thinking. The main issue as to why people bleed post thrombolysis is because usually it's because they've used up a whole load of clotting factors to clot their stroke in their head. And then we've given TPA, which has then broken down all that fibrin, and then presumably the body's trying to kind of make more fibrin, and you're kind of in this sort of consumptive process of using clotting factors to make a clot, which is then getting broken down by the TPA. And so the concern when they then bleed, because you wouldn't expect them to necessarily kind of bleed, ideally you give TPA, it will digest the clot in that specific area because it will bind to the lysine there and get activated and everything like we talked about, and you wouldn't expect it to go around just wreaking havoc and breaking down fibrin where it needs to be and causing bleeding. And so the assumption is that they must have just kind of got this consumptive coagulopathy post thrombolysis. And I think it's useful to remember that, because that's fundamentally where we can try and help. Because obviously there's no reversal agent for TPA for alteplase. Plus also we know the half-life's only 5 minutes. So yes, the duration of effect is long, but the free floating alteplase is only around for like 5 minutes. So it's more about how can we support their clotting. And you said FFP, and that's really good. That's what we would be looking to give, because that's got all your balanced clotting factors, hasn't it? You're basically just giving plasma by giving FFP. So you'll have your fibrinolysis inhibitors in there, like your natural ones. You'll have your clotting factors in there. You'll have everything. So yes, you would check your bloods, but you would also administer FFP at 12 mils per kilogram. And then anything else that you can give to sort of help switch off fibrinolysis?
TXA?
Yes, tranexamic acid, which we'll come back to. But yes, 1 gram 3 times a day. And you can give that IV. And then also you're going to check the Klaus fibrinogen assay and make sure that it's above 1.5. And if it's low, then you can give cryoprecipitate to replace that. And that's basically all you can do. But it's just, I think it's a good case to just think about kind of the effects of what can happen to your clotting cascade when you give alteplase, and why therefore some people get a hemorrhagic transformation.
I guess that's a really good point. I guess in my head, despite the fact you literally just said it, that it alteplase specifically targets the clot, I thought I've made them bleedy. But actually what I've done is I've reduced the clot that's there in a person who's now consumed all of their factors.
Exactly. Yeah. Okay, let's talk about tranexamic acid. My husband laughs because he thinks I'm obsessed with this drug. Is it sad to have a favourite drug? I don't know.
No, not at all, Harry. It's very cool.
It is a really cool drug. Do you know the story of how TXA was discovered?
No, but by looking at your smiling, glowing face, you are desperate to tell us.
Oh yeah, I watched a documentary on it. Don't ask why, but
we won't.
It was discovered by this lovely Japanese lady and her husband, and it was after World War II, and Japan just had like 2 nuclear bombs dropped on it, and she lost her lab, and so she set up.
Sorry, Harry, I'm going to have to interrupt you because you haven't tried to say her name, and I'm very excited to hear you murder another name, please.
Utako Okamoto.
We're all happy, thank you very much.
And she basically set up this lab in her living room, essentially. And she said she wanted to discover, her quest was to treat women who were bleeding after childbirth and to discover a drug that would reduce this. And she said she wanted to do it to kind of, to give something back to humanity. This is after somebody has just lived through 2 nuclear bombs. Do you know what I mean? It's kind of like, it was quite a moving documentary. I'm not going to lie.
Yeah.
And she didn't do it for fame. She didn't do it to like increase her career. She didn't do it for any reason. She just did it because she wanted to do good. And she discovered TXA, and she then obviously the woman trial. I hope you've heard of the woman trial. Have you heard of the woman trial?
No, this is my ignorance. I'm gonna have to go away and do some reading.
Well, in a nutshell, the woman trial was a hallmark trial, which basically showed that use of TXA within 3 hours of bleeding in postpartum hemorrhage basically saves lives. And it was a big trial, recruited 20,000 women, and it was a randomized, double-blind, placebo-controlled trial. And they started recruiting women in 2010, and they finished recruiting in 2016. And she died before the results of the trial. But in this documentary, she said, like, I know it's going to work. I just know. And she was right. And like, I just think it's very moving. So yeah, she found TXA. It's never been kind of an expensive patented drug. And now obviously we've got the CRASH-2 trial, which showed that it reduced your risk of death from bleeding and trauma by 1/3 if it's given within 3 hours. and it reduces all-cause death at 4 weeks in trauma patients. And then the CRASH-3 trial showed that if you give it within 3 hours of head injury, then you reduce your head injury associated deaths. And it also has saved countless lives in postpartum hemorrhage in women. It's totally safe. It's really cheap. It's given 1 gram 3 times a day, same dose oral as it is IV. And it was all due to this lovely lady and her husband working after the World War II. I just think that's such a lovely story, that there are some really good people in this world.
Yeah, very inspiring story.
Yeah, it's lovely, isn't it? So anyway, I'll stop going on, but I love the drug. I think it's great. It's really good for reducing blood loss around surgery. It's, it's a big part of patient blood management. And its mechanism of action, do you know how it works?
It's something to do with lysine. I don't
Yes.
know what it does.
Yeah, exactly.
Yeah.
Well, we talked about lysine, right? What was the role
Yeah.
of lysine? Like,
It was the binding point, wasn't
yeah,
it?
exactly. On
Yeah.
fibrin. Yeah, it's your landing points for your plasminogen and for your TPA on your fibrin clot. And so what TXA is it's a lysine analog. So it acts as like a decoy for your TPA. And so your TPA binds to that, and your plasminogen binds to that, and so it doesn't bind to the clot, and it allows clots to be stabilized. So it basically protects clots. And it's a super useful drug. I mean, we use it all the time in patients with low platelet counts, in MDS, in AML, where they're on best supportive care, people with platelet disorders, people with mild haemophilia A, with von Willebrand's disease, around procedures to prevent bleeding. I mean, probably the only time that you can't use TXA, which there was some kind of not great evidence, was the HALT-IT trial, where it said that maybe we shouldn't be using it in upper GI bleeds. But other than that, it's a great drug. You can use it around the mouth as a mouthwash. You can soak it in gauze and apply it to wounds when they won't stop bleeding. I'll stop going on about it, but it's all thanks to this lovely lady from Japan. So there we are. So that's TXA. It's a lysine analog, which makes complete sense when you just know just enough about the process of fibrinolysis. So yeah, great. And then you mentioned D-dimer, the D-dimer test, David.
The dreaded, yes.
I mean, to be honest, we don't get many phone calls about D-dimers because you're not supposed to use them in inpatients. I think once they've been in for 24 hours, it's no longer validated. You don't use it in pregnant women, and you don't use it in children. So it's much more of a GP land thing, using a D-dimer. But yeah, basically, well, what do you know about a D-dimer assay?
So from what I understand, it picks up the fibrin degradation products that we talked about earlier.
Yeah.
Is it an ELISA?
Yes, it
I
is.
made that up. Yeah.
No,
so and then you get back a value. The tendency is I always get asked to do them when somebody's run out of ideas and goes, does this person have a PE? And we do it, and it comes back mildly raised, and then we're forced to do a CTPA. That's my experience of a D-dimer.
Yeah, exactly. So they've got a really good negative predictive value. So if they come back negative, you're pretty sure that they haven't had a PE or a clot of any kind, which makes sense, right? Because how could you possibly have a clot without having activated a bit of fibrinolysis? Because we know that the two get activated at the same time, right? So how are you going to have a major clot and have a negative D-dimer? It's basically not possible, which is why it's got a great negative predictive value. So it's great at ruling out a PE or a DVT. But as you say, it can be positive in loads of other things like infection and cancer and anything that is causing a bit of clotting and a bit of breakdown of clot. And so, yeah, it's positive a lot. And those are usually the calls that you get. But to be honest, I honestly don't get many calls about D-dimer tests because it's generally not that useful. If you were to do a D-dimer post a thrombolysis patient, it would be like, off the scale. And sometimes those FDPs can actually become part of the problem. I should have said that when we were talking about that bleeding patient post thrombolysis. The fibrin degradation products themselves can actually interfere with that final step. We talked about it in the thrombin time podcast, because it can prolong your thrombin time if you've got loads of fibrin degradation products. And so you can see that in things like DIC as well. Yeah. Cool.
Nice.
Okay, well, I think that is the bottom of the clotting cascade. I think we've actually finished, which is very sad.
Got our feet on the ground.
Don't worry, because we're going to be moving on to all the exciting clinical aspects of clotting next. So, Yeah.
Oh, and there's that grin again. Great. You're in for it, guys.
Lots to look forward to. Shall we recap then? So, what are
Yeah,
our
please do.
3 take homes today? I would say 1, factor 13 is not measured by any of your standard clotting tests because it is cross-linking fibrin, which is after the point that the lab machines have stopped measuring, essentially. And so you have to do an ammonia release assay and an ELISA. 2, fibrinolysis is activated any time that the clotting cascade is activated. The key player is plasmin, which is your key enzyme, which breaks down fibrin into fibrin degradation products. And your key substrate is plasminogen, which is the inactive form of plasmin. The key activator is TPA, and both TPA and plasminogen really benefit from binding to lysine on the fibrin clot, and that is one of the ways in which we control spatially where fibrinolysis occurs. We've got lots of negative feedback loops with our fibrinolysis inhibitors, which also control fibrinolysis in a temporal manner. And then 3 is probably, well, I want to say 3 is that TXA is a great drug. It's cheap and it's really effective. And it was made by a very lovely person.
I think that's the bit we're all going to take away, isn't it?
Good. All right. Well, thanks for treating me to this bank holiday.
Yeah, giving you the floor so you can talk about the things you really care about. Yeah, no,
Yeah.
This is what this podcast is for.
Yeah, great. And yeah, thanks for everyone listening at home. And do email us in if you have any questions or topics you want us to specifically cover.
Yeah. And again, thank you to Hader, who makes all this happen by stitching this all together and removing all the rubbish that we talk about in between.
Yeah.
So, yeah, thank you.
Yeah. Okay. See you later.
See you again.
Bye. Thanks again for listening to Basics to Brilliance Haematology Podcast. If you enjoy our series, please don't forget to like, leave a review, and hit subscribe to never miss an episode. See you next time.